So thank you very much, Dr. Lubner, for this great lecture. So we have several questions, and it's very interesting that we have questions from all over the world. So you have the first question, give them in order. This is from my friend Dr. Canella from Palermo, Italy. So he's asking, he's saying, I have a question regarding the imaging features of intrahepatic cholangiocarcinoma in cirrhosis and normal livers.
I think I know. Some of the literature has suggested that maybe some of these small cell type, that arise from the hepatic stem progenitor cells, that tend to behave a little bit better. It seems that those may be more common, and I'm not sure that this is a hard and fast rule, but it seems that those may be more common in patients with liver disease. And so some of the examples that I showed, they kind of have that look. They're a little bit more peripheral. Maybe they have a little bit more prominent arterial enhancement. Sometimes it seems like they behave a little better, or at least I've seen multiple series now that have come out in the literature where these smaller lesions in cirrhotic patients are not eligible for surgery, so we end up using local regional therapy with reasonably good success. I've seen several series of cholangiocarcinomas with ablation, which in past, we haven't really thought about ablation as much for the, so maybe his question is regarding that, and I'm not sure that I know the answer as a hard and fast rule, but some references have suggested that these smaller, maybe slightly better prognostic lesions may be more common in patients with viral hepatitis and cirrhosis than normal livers. I'm not sure if I'm answering his question, and I wouldn't say that that's a hard and fast rule, but I have seen that described in some references, and I have seen that in our clinical practice a little bit, that we've been able to treat some of these with local regional therapy when in the past maybe we wouldn't have done that.
He apologizes because his microphone didn't work, so he's trying to fix it. But we can move to different questions now till we go back to Dr. Canella. The second question is from Dr. Mohammed Eid from Egypt. Mohammed?
Yes. First of all, I would like to thank Dr. Lubner for the excellent talk. It's really interesting. My question is about the IPMB. How can we differentiate it from the intraductal growing type of cholangiocarcinoma? Thank you.
Yeah, that's a really good question, and I think very challenging. Let me just flip back. Sometimes I think and I think it depends. If the intraductal growing type is making a lot of mucin, I suspect it could look almost identical. Let's see if I can find it. But yeah, I struggle with that as well. I think, when I see just sort of that very tubular biliary ductal dilation with no papillary projections, no definite intraductal lesion, I tend to think more about IPNB. If it has more papillary projections, especially if it has like a single prominent papillary projection that's causing biliary ductal dilation, then I start to think about intraductal growing type. And to be honest, I think, both are troublesome lesions, because I think if you see a prominent papillary projection in an IPNB, you worry that there's an invasive component, which could be sort of an intraductal growing type. So I'm kind of wondering if it's sort of a spectrum of disease, and whenever I see enhancing mural nodules, maybe it becomes a little bit semantic whether it's an IPNB with papillary projections in a growing or developing invasive component versus an intraductal growing lesion. But I will say that the intraductal growing type, it does seem like it's very uncommon. So in all of the cholangios I've seen, it's really the minority, maybe one or two. It does seem like the biliary ductal dilation, or the tubular ectatic biliary tree that tends to be more left-sided, is more prominent with IPNB, and it may be plus minus the papillary projections. So I feel like I see the IPNB a little bit more commonly than I do the intraductal growing type. And if I see papillary projections, then I maybe diff it as both and just say that it's sort of worrisome, and surgical consultation is probably warranted. I'm not sure that I answered your question. I think it's a really hard imaging problem, and I'm not sure. Maybe you have some ideas about how you differentiate.
Perfect. Thank you. I think that, like you said, whenever it started to show enhancing nodules, so I think that it's really semantic, because the treatment is the same. We have to resect it.
Right. I think so. Yeah, if it can be resected.
Yes, of course. Okay. Thank you.
Yeah. Thank you.
So our third question is from Argentina, from Diego Heberman. And as I'm telling you, like when our Brazilian friends are not here, then he can breathe and he can ask questions. Diego, do you want to give the question? Diego?
Yeah, thank you very much. Thank you very much, Dr. Lubner, and congratulations for the presentation. Great. Now, I would like to know if you have any experience with spyglass for peripheral cholangiocarcinoma, or even for IPMB, that we are seeing a lot, and it's a challenge diagnosis.
Yeah, absolutely. We are doing some spyglass, and so I think you know, that last slide I showed just with brushings, et cetera, I think you're right that if you do more advanced endoscopic procedures, and that is how, for example, the woman I showed you who had the atrophy and the biliary ductal dilation, that was ultimately how she was diagnosed, was endoscopically, and I think they found a lot of mucin, and there was a plaque-like papillary projection that they were able to biopsy. I think we are seeing more of that. I guess I don't know exactly sort of what the sensitivity and specificity is in this particular setting. I don't know if you've seen numbers, but it does seem like that can be really helpful, because I feel like sometimes I look at these and it looks to me like segmental ductal dilation with some atrophy, and I'm like, is this chronic obstruction or is this an IPNB that's making mucin? And maybe you'll see that thread sign, you know, maybe you'll see that meniscus of, you know, contrast around mucin, but I think it can be very hard to be confident about the diagnosis and moving to an endoscopic approach where either they see a whole bunch of mucin or they find, you know, something that they can take a bite of, either with, you know, spyglass or some other endoscopic technique. I think that's really helpful.
Thank you very much. Here in Argentina, we still don't have. We still don't have the technique, but. No, we don't still have the technique, but we are very hopeful because some equipment are arriving, and we have a lot of problem with periductal infiltration type of cholangiocarcinoma, and we are very hopeful of that technique.
Absolutely, and I guess I would say if it's a, you know, like a periductal infiltrating lesion that has a mass component, then sometimes we have good luck, you know, trying to get it percutaneously. But sometimes, you know, if it doesn't have a mass component, doing a percutaneous approach, unless I guess you do a percutaneous transhepatic cholangiography sort of approach, is challenging.
Thank you very much.
Thank you. Thank you, Diego.
Thank you.
Thanks, Dr. Lubner. So the next question is coming from my friend who's fighting against corona in New York, and he's working in #2 Cancer Center. Dr. Do.
Hi. First, great job, Meghan, for summarizing such a large topic elegantly.
Oh, thank you very much, Richard.
I have a question regarding the large duct, small duct sort of carcinogenesis concepts. You know, I think I'm wondering how much of it is specific to Asia or generalizable to the entire Western countries as well. Given that our experience here at Sloan Kettering, large duct, small duct, it's been a bit more confusing, not as clear cut as that described previously in Korea, for example. And if so, is it really actionable? Does it help to understand which precursor it's coming from on a clinical management basis, or does the morphology and location matter more?
Yeah, that is a really good question, Richard, and I have struggled with that too, because it seems relatively straightforward in the description here, but man, you know, sometimes I feel like it has features of both, or you know, it has a lot of sometimes where fibrous stroma falls in this large duct versus small duct classification is a little confusing to me. So I agree with you. I think in some populations it may be a little bit more clear cut than it is here. And I agree with you. I think it's hard at this point, you know, for it to be super actionable. As I said earlier, though, the one place that we end up thinking about it a little bit is in our patients with liver disease. So if they don't have, say they're not surgical candidates, and they've got a lesion that's small and shows, you know, pretty prominent arterial enhancement, we may sometimes as a group will say we might do better with local regional therapy here. And ultimately, I don't know that we're really impacting our clinical decision making, because maybe they don't have any other options. So that's just what we're going to try. But it just seems like anecdotally in our patients, to the earlier question that we saw, sometimes our cirrhotic patients seem to have these more, what I think have these peripheral small duct features sometimes, and ultimately it seems like local regional therapy works for them. But I agree with you. I'm not sure it's as clear cut as this. Sometimes I feel confused when I'm trying to apply this classification to all patients, because maybe we need to flesh out a little bit more where this is most applicable. And as of now, I think there are a few clinical scenarios where we're using this to guide our treatment, except in that where local regional therapy might be an option. I don't know. What are you guys? How are you guys handling it?
Yeah, well, first I feel much better now that I'm not the only one struggling with
Yeah, I've really struggled with this, and I do find it kind of confusing, but very interesting. If I could draw some conclusions about the behavior based on the imaging, I always liked that. But you're right. I feel like sometimes they have features of both. Sometimes I'm not totally sure. But anyway,
yeah,
that
I think
viral hepatitis group, sometimes we think about it, I think.
To answer your question, I think if it overlaps in any way with an HCC, it almost gives the interventionalist license to local regionally treat it during a biopsy. So it's kind of a more, while it looks small enough to ablate, and I'm going to make sure that it is HCC or perhaps cholangio, but I'll ablate it anyways, which may or may not be the right thing to do. But the results, like you said, seem to be pretty good in terms of local regional control when the tumor is small. So it's probably more predicated by size than by appearance. So anyways, that's just my observation.
Yeah, I think that's true. And one thing that we've sort of historically thought with ablation is that tumors that are really fibrous just don't seem to heat as well. It's just hard to really heat that fibrostroma and kill those cells. And so these smaller homogeneous arterially enhancing lesions seem to heat a little bit better, maybe because they have less fibrostroma. And again, it may just be a function of their size, as you say, but I've been surprised in some of the really, I mean, I've seen some pretty good outcomes with local regional therapy, some series that have come out recently, and maybe that's part of why is lesion selection, as you're saying.
Thank you.
Yeah, thank you.
Thank you very much, Richard and Meg. Last question, we have it from New Delhi, India. Sandeep, do you want to give the question?
Oh,
yes, sir, we hear you.
good afternoon, ma'am. Good afternoon, ma'am. Thanks for a wonderful lecture. I wanted to ask you, have you ever observed increasing frequency of nodes, especially around the liver hilum, in cirrhotic patients with intrahepatic cholangiocarcinomas vis-a-vis HCCs?
So you're saying that you think that cirrhotic patients with intrahepatic or with cholangio tend to have more nodal disease?
Nodal disease, especially along the hepatic artery. And they sometimes give us a clue that you are dealing, even if it's a smaller lesion close to the liver hilum, you're actually dealing with, not with an HCC, but maybe either a biphenotype or ICC. So we tend to do a lot of frozens and a lot of endoscopic ultrasound guided biopsy of those nodes before we take any decision.
Yeah, you know, it's tough because I feel like sometimes in patients with viral, well, depending what their cause of liver disease is, especially viral hepatitis, I feel like they have a lot of portohepatus nodes to start. But I agree with you. I feel like just anecdotally, and I don't have a lot of great data on it, you know, when I start to see abnormal nodes, especially if they look kind of necrotic in the portohepatus, that does make me worry a little bit more about cholangio than HCC. We've seen a handful of HCCs do that, but you're right. It seems like cholangio, maybe just as a feature of it.
Yeah, I agree, because there is 90% of nodes in chronic liver disease are benign, even if they're of large size. But especially with cholangios and heterogeneous nodes, we really tend to biopsy those nodes as well a lot before taking a final decision. And another second question, do you have any experience of advising or performing liver transplant in locally advanced hilar cholangiocarcinomas?
Well, you know, we used to not do it at all, and now we will do it using the Mayo protocol, which, and maybe some of the other people on the line are doing this as well. It's a pretty rigorous patient selection, so the selection criteria, you know, involve how you make the diagnosis, whether or not a mass is present, and if there is a mass, it has to be smaller than a certain size, and then they have to go through this, as you say, biopsy or lymphadenectomy of some of the portohepatus nodes. They go through a pretty stringent chemoradiation regimen that takes, I can't remember exactly how long, like 6 weeks. And then if they make it through all that, then potentially they can be transplanted. And I think essentially what they're doing is a lot of people fall out, like they don't make it through the whole thing because their disease progresses. So I think it's a way of sort of selecting people with better biology. But yes, we have, if people meet the criteria for the Mayo Protocol, and I can get exactly, I don't know them all off the top of my head, maybe someone else does that's on the call, but we discussed it at, multidisciplinary conference. If we think they meet the criteria, then they go through it, but it is a pretty tough regimen to get through, and I would say a fair number of patients don't make it all the way to the end, to the transplant.
Thank you. Thank you.
Sure thing.
Great, thank you very much. And Meg, would you like to make any comment at the end? I mean, we don't have any more questions, so would you want to say anything?
Well, I just wanted to say thanks to everybody for coming. I really appreciate it, and I really appreciate your thoughtful questions.
So thank you very much, Meg. We enjoyed this lecture a lot, and we thank you everyone for coming from all over the world to attend this online webinar, and in particular today's lecture, which was a terrific one. So thank you very much, Meg, again, and look forward to further collaboration on other educational materials. And thank you very much. And I'm getting a lot of feedback here. Everybody's thanking you from Palermo, from
thank you.
Argentina, from India, from Egypt, from Saudi, from Spain, from Colombia. So those
thank you so much.
all
thank
colleagues. And that's what makes it inspiring, quite honestly. So thank you very much, Meg.
Yes, yes. And thank you so much for the kind invite, Khaled. I really appreciate it.
No, thank you very much for making it, Meg. I know that you're very busy now, and that this is wonderful, and you've taken the time and efforts to do it. Thank you.
Thank you all. Take care.
Bye-bye.
Okay, bye.